Next, we're going to hear from Dr. Brett McCray from the University of Michigan.
Here we go. Okay, so it's a pleasure to be able to talk here today and follow these great talks, which have really set up, I think, what I want to talk about. So I kind of want to go through our journey with trying to get to a clinical trial for TRPV4-related neuromuscular disease, or CMT2C, as it's sometimes called. And what I want to do is kind of outline our journey and try to show you what I think has gone well, what our challenges are, and hopefully kind of point out some lessons that I think have helped us to get to the point where we are. So this is a very rare form of CMT, and to be at a stage where we're hoping to have a clinical trial, I think suggests that some things have gone right with this process. So hopefully we can learn from that. All right, so that's my disclosure. I am part of the natural history study I'm going to talk about with some funding. I have no financial interest in Actio, but I have a strong scientific and medical interest in what we're trying to do. So Mary really outlined kind of what I wanted to point out with this slide, is what she called I think the therapeutic circle, or something to that effect. So just to give you a sense of what I want to talk about here. So we have this process where we go for a genetic disease from gene discovery, and this really ramped up in the 80s and 90s, then on to what I call fundamental science to try to understand the pathophysiology of the disease, identify potentially therapeutic targets, and then on to development and testing of therapies, usually in preclinical models, on to clinical trial readiness, which we just heard about is such a key component of this process, and then on to clinical trials. So for TRPV4-related disease, this really started back in 2010 with the discovery of TRPV4 mutations that caused different forms of neuromuscular disease. And so there were three papers and really three different phenotypes that were described, a sensory and motor phenotype, CMT2C, and then two spinal muscular atrophy phenotypes, which were pure motor phenotypes. And we now know that this is really a continuum, sort of like what we heard about yesterday with SMART and CMT2S. So I don't really know that these labels are that useful, but there's really this indicates a broad spectrum and continuum of disease with different manifestations in different patients. So over the coming decade and more, what became clear is that the mutations that cause this disease in TRPV4 have a unique functional signature. So TRPV4 is a calcium permeable ion channel that sits at the cell surface. And the mutations that cause disease cause a gain of ion channel function. They activate the channel. You get excessive calcium influx. And so this was really when Charlotte Sumner discovered these mutations, what really drew her to studying this more. So this immediately suggested there could be a therapeutic strategy. You inhibit the channel, you could potentially treat this disease. And that was true in the case of in vitro models. So the next step was to develop animal models to test this idea that inhibition could be therapeutic. And so this was also really pivotal in this entire process of trying to get to a place where we can do a clinical trial. So I know there's been some de-emphasis of animal models, but in this case, the animal models, particularly the knock-in mouse model, was really provided powerful evidence, preclinical evidence for a therapeutic strategy. So we looked at fly models and also the mouse model. And then another really important aspect of the mouse model was it taught us something completely unexpected about disease pathogenesis. So this was work that I helped with in Charlotte Sumner's lab, is really led by Jeremy Sullivan. So this is the knock-in mouse model of TRPV4-related disease. These mice develop a really remarkable phenotype where they have this four-limb predominant weakness, head drop, and this progresses over about 2 to 3 days to complete lethality when the mutation is in the homozygous state. Remarkably, these mice can be completely rescued with treatment with a small molecule TRPV4 antagonist, in this case, GSK219. So it completely rescues lethality, completely rescues the motor deficits, and can even be given after onset of these deficits, and it can reverse the problems that these mice develop. And the other really surprising feature I mentioned is that if it turns out in these mice that the phenotype is driven not by TRPV4 expression in motor neurons, but by expression in vascular endothelial cells, resulting in leak of the blood-brain barrier and blood-spinal cord barrier. So completely unexpected insight that really was only possible by studying a preclinical animal model. I should also mention that leak is completely rescued by the TRPV4 antagonism as well. And so this provided really strong evidence that this treatment of this disease with an inhibitor could be potentially beneficial for patients. So the animal models were really key here. Another key development was that as we were getting this mouse data and publishing the fly work, we were contacted by a patient, Stephanie Carmody, who is somewhere here in the audience. And she had managed a patient Facebook group. And so she reached out, we established a connection. We had some Zoom meetings where we talked about our research. They talked about the patient experience. We learned a lot from each other. We learned things about this condition that we didn't know. And that really established a great working relationship and allowed us to develop a patient registry through the Inherited Neuropathy Consortium. And we used that to then do some cross-sectional studies of this phenotype. So it's an unusual phenotype. It's different than other forms of CMT, and we had a lot to learn about it, and we still have more to learn. And so what did we learn from those efforts? So this is a motor predominant and non-length dependent form of neuropathy. So we heard a lot about the typical length dependent features of CMT. This is not that. It's also quite heterogeneous. So each patient looks a little bit different than the next, which is a real challenge. So we found that the age of onset varies widely. Some patients have early onset within the first 2 years of life or congenital. Some patients have onset very late in life. The weakness, as I mentioned, is non-length dependent. So what that means is proximal muscles are affected and so are distal muscles. So if you compare to, say, CMT1A, where you get mostly length-dependent weakness, mostly in the feet and lower legs, these patients have much more proximal weakness affecting muscles in the thighs, muscles in the shoulders. So a very different pattern of symptoms. We found that there is some sensory loss present, but this is really not a predominant feature of the disease. Some patients can be shown to have some vibratory sensory loss, but this is really kind of a minor aspect of the condition. What is a more common problem in this disease is actually vocal fold weakness and respiratory manifestations. So we were able to see that a high number of patients had symptoms related to vocal fold weakness, voice symptoms, stridor, and hoarseness, and a lot of shortness of breath and frank abnormalities on pulmonary function testing. And we also, when we asked patients what was most important to them, we learned a lot. So it really turns out that the motor symptoms and these voice and respiratory symptoms are really driving the patient experience, whether it's weakness of the arms or legs or trouble walking or problems with breathing or voice. This seems to be really what the patients care most about, which I think we should also care most about in a clinical trial. So to learn even more about this condition and really try to figure out what we could measure an outcome assessment in a clinical trial, we started a natural history study. And so we were fortunate to get some early funding from the MDA, and now we have funding from Actio Biosciences as well to do a really extensive natural history study. So this is now run through Johns Hopkins, led by Charlotte Sumner and a large group of clinical researchers. And so this is a really intensive 2-day study. Patients travel expenses are paid for, all of the assessments are paid for with the help of the funding. And patients come to Johns Hopkins for this really intensive study where they see neuromuscular neurology. They undergo all of the different scales for CMT that we mentioned. Because of the proximal shoulder girdle weakness, we've also added the facioscapulohumeral dystrophy COM as part of our assessment. They get an EMG, they see ENT, get speech and language assessment. And then we're also looking at a number of potential biomarkers and novel outcome assessments. So looking at speech, doing video laryngoscopy to look at vocal fold movement. We are doing brain MRIs with a special leak protocol to determine whether the same kinds of leak signature is present in patients as we see in mice, and looking at some exploratory and validated blood and urine biomarkers. So what have we learned so far? There's been about 25 patients that have been enrolled in this natural history study and 6 patients that have had their repeat visit at year 2. So this is a depiction of what we've learned from the pattern of weakness. So these numbers are the MRC scale, with 0 being no movement up to 5 being normal. And this is an average across all the patients. So the darker red color indicates more weakness. So you can see there is more distal lower extremity weakness, but you also see there are abnormalities of muscles throughout the body, particularly even neck extensors, shoulder abduction, hip flexion, knee flexion, extension. So it really gives you a picture of the diffuse non-length dependent weakness in this condition. We've looked at some of the established outcome assessments that Mary talked about earlier. We see a wide range of scores, and we see these are fairly noisy. And so, as we suspected, these are not really designed for this type of neuropathy, given that they're designed to detect length-dependent dysfunction. And so, these have not performed particularly well for this condition. But they do correlate with each other. They do seem to be capturing some element of the disease. So, I think they still may have some value. And if we kind of hone in on some of the sub-items. So for example, here in the CMT functional outcome measure, we see that some items do perform well, and they seem to predict the total score, indicating that they may be driving the score. So the 30-second chair stand test, for example, and the 6-minute walk test seem to perform well, whereas a sensory measure, pinprick, does not really seem to correlate well with the overall outcome. So again, highlighting this as a motor predominant disease. So we've also had a sneak peek at how these are performing longitudinally in just a small number of patients. So that's a major caveat here. If we look at the FOM, we look at the CMT exam score and neuropathy score, we don't see significant change over 1 year. And we also, if you look at a patient-by-patient level, there's a lot of variability in these measures, I think just indicating that they're challenging to apply to a non-length dependent neuropathy. We are also doing dynamometry, so quantitative testing of certain muscle groups in the arms and legs, and very small numbers here, but we do see potentially a sign that there may be decrements over time with these kinds of measures. So indicating maybe there is some way that we can capture changes in strength over the course of a study, and hopefully an improvement with an intervention. We've also seen that many patients have problems with reductions in functional vital capacity, both in the seated and supine positions, with majority of patients being less than the predicted value. And again, small numbers, but we do see some potential signal that this may be progressive over time. So again, maybe something that we could use as an outcome assessment with an effective therapy. We have looked at neurofilament levels. I would say that the consensus so far is that they are not dramatically elevated, but there may be some subset of patients that do have significant elevation. So the 0 here is the mean, and then 1 is 1 standard deviation above the mean. So a number of patients are above that 1 standard deviation level. So potentially something that we could also use in the clinical trial. One thing that we think is particularly promising is evaluation of vocal fold movement. So patients are all getting these video laryngoscopies where we can actually look at the vocal cord movements. And so the main deficit in this condition is weakness of vocal fold abduction. So what happens normally when you breathe is the vocal folds open, and that opening is what's particularly impaired by in patients. And so what we're doing is measuring the angle, the maximum angle at inspiration as a measure of vocal fold movement. And this is work largely led by Ali Turkamani from Actio Biosciences. And so you can actually use machine learning to measure this angle pretty reliably and consistently. And we see the maximum angle in all of the patients we've looked at is reduced compared to the normal 55% or greater. And again, small numbers, but we do see that I think it's 5 out of 6 patients have shown a decrement over 1 year in the vocal fold movement. So potentially a signal that we could use in a trial. So where are we now? Actio, who is going to talk tomorrow about what their work has been, has developed a novel TRPV4 inhibitor. They just have been doing a 1A trial in healthy volunteers, and they've seen really good pharmacokinetic and dynamic properties. This is a once daily pill, and it's behaved very well in their studies so far. So the plan now is to eventually take that into a 1B clinical trial to assess safety, but also to explore a number of these potential outcome assessments that I've mentioned. So I kind of wanted to leave with a little bit of some conclusions, but a lot of questions that I think are relevant to the field in general. So I think for this condition, we're learning this is motor predominant, and the voice changes and the respiratory abnormalities are really important to patients. And I think that's where we want to focus for our outcome measures in the trial. I mentioned that heterogeneity, which is a real challenge in this condition. So I think that's going to be a real issue that we're going to have to contend with. And so how can we do that? We heard about composite measures, how those are really not favored by the FDA. In this condition, they also have the potential to sort of mask an effect on one domain if other domains are not changing. So one question is, can we really design a trial that focuses on specific deficits in individual patients that may be changing? If one patient has progressive vocal fold changes, can that be their outcome versus strength in another patient? I think these are challenging questions, and we don't know the answer yet. We also are kind of behind the curve here on getting muscle fat fraction data. So we're trying to do that now as part of the natural history study. We don't really know what patterns we're going to find. There may be certain muscles in the arms or legs that show changes over time that are kind of in that wheelhouse range that Mary described, where patients are most showing the most change. So we need to try to figure that out and see if that's something that's going to be important for this trial. And then what outcome measures would be acceptable? Certainly, neurofilament has validation in the ALS space. We don't know whether it's going to be useful for this patient population. Vocal fold movement changes there, and the quantification we described has never been used in a clinical trial. So that would be a novel question to pose to the FDA, whether that would be something we could use. There's voice-related quality of life outcome measures that we will incorporate. But again, uncertain whether those can be used as a primary or secondary endpoint. And then we heard a nice discussion about patient reported measures that we're going to incorporate. And then I think another big challenge for us and for many forms of CMT is how do we really maximize patient identification for natural history studies, for treatment trials, and if we have a treatment to then get that treatment to patients. And I think that's something we all need to tackle as a community. So with that, I'll just recognize the many people who've helped with this. So the patients and families particularly have really driven this forward in an incredible way and have been a source of inspiration and taught us a lot. And we wouldn't be where we are without that early engagement and continued engagement with the community. Charlotte's lab and her clinical group at Johns Hopkins has done all this work now to evaluate these patients in this really rigorous evaluation. So it's been a tremendous amount of work. So with that, I can take some questions.
Be interesting and nice talk. Can you postulate why there's such phenotype differences? Like it's extraordinary, the differences between the very onset congenital and the later onset.
Yeah, we really don't know. I think one observation is that there's a population that has congenital onset and then there's sort of a period of stability, it seems, and then maybe more progression of disease later in life. So it almost seems that there's two waves. It's kind of a developmental process that some patients get and some patients escape, and then maybe a more progressive part. But why that is, we really don't know. We know that the severity has nothing to do with the genotype. It's not uncommon that children come to attention because of these congenital features and their parents didn't know they had the condition, but we find signs in them. So the mice give us some clues that there's a lot of background variability in the mice. That's just subtle changes in the genetic background can really affect the manifestations. And so there's probably some genetic factor that we don't know, but yeah, and it makes it challenging for a clinical trial, I think, that heterogeneity.
So is this on? Yeah. So usually so TRPV4 is a TRP receptor, and usually, you think of those as either temperature receptors or chemoreceptors. Do you have any idea why axons need it and what it's doing for them?
So it's really, I didn't get into this. It's expressed in a small percentage of sensory neurons. There's really no good data that it's expressed in motor neurons, period. Mice, humans. We really think this is not a cell autonomous disease, that is TRPV4 in the blood vessels that's causing this disease through that leak mechanism. So what it's doing in blood vessels is probably responding to shear stress, the flow over the cells. it seems to be primarily driving pathophysiology rather than normal good physiology. And so one thing that gives us confidence that we can inhibit TRPV4 safely is you can knock it out there in mice without a serious phenotype. There are people in the world that have homozygous loss of function alleles that seem to have no disease. So it seems to be a non-essential gene that contributes to a lot of pathology.
Hi, Brett. Question online over here.
Oh,
Yeah. The question is, given the current upheaval in the FDA, do you think there's any chance they would be more open to using functional endpoints for trials and using the natural history for controls like they did for the case of HSP trials?
wow. I'll say I have not ever been part of direct conversations with the FDA, so I'm probably not the best to answer. I would defer that to others who have had those conversations.
Brett. Nice work, and it's interesting result with the GSK molecule that you used that shows complete revival. That's an antagonist, and this is a channel we are talking about, right? So can channel function be stabilized instead? Is there a possibility for using stabilizers?
It's possibly for use.
Channel stabilizers.
I'm not sure exactly what you mean by channel stabilizer, I guess.
Because I mean, TRPV channels, I'm supposing that these are calcium channels and increases calcium into the cells, right? So if there's a way to somehow stabilize that functionality to the fact that you reduce that calcium intake or calcium release.
Yeah, that's what the drugs are essentially blocking opening of the channel. So they're not so it's not changing the expression, localization, it's just really blocking opening.